Chapter 17, Ambulation, the impact of age-related changes on functional mobility. In order to perform a proper gait analysis, we need to recognize normal gait and how gait changes as we age, understand the functional requirements of ambulatory with and without assistive devices, describe the common age-related gait changes, and then be able to assess elderly gait and create an appropriate plan of care. This last one will be something we will be doing in lab, in class. With the reliability of gait assessment, research from a few years ago showed that the results among experienced raters and inexperienced raters were comparable to one another. This study used 30 patients that were seen in physical therapy where a gait assessment was done via videotape. The conclusion of this study showed that structured visual gait observation by use of gait analysis, as described in the study, was found to be moderately reliable. Clinical experience appears to increase the reliability of visual gait analysis, which makes sense. The more clinically sound we are and the more we learn over the years, the better we're going to be at being able to reliably assess gait. But that doesn't mean we can't do it today. Evidence-based gait analysis. There are a lot of different gait tools out there that do not provide data on reliability, validity, etc. Evidence really is lacking for the best way to assess gait. The best recommendations that have been found are making sure to correlate the gait assessment to your clinical exam. Make sure also to correlate that gait assessment to the function and the patient's own goals. And then using some sort of structured assessment. The observational gait analysis, or Rancho Los Amigos, is most typically used clinically. Now, there's a few different ways to analyze gait. We want to make sure that we're looking at it from a variety of different ways. We want to make sure that we observe the patient from the sagittal plane, the frontal plane, and with static and dynamic assessments. Make sure and identify also any gait deviations that we're seeing and any characteristics we see that are different from what we would normally expect to see. Also on this, you want to make sure and see if there's any asymmetry between the right and left sides. And then determination of cause. So this is where our assessment comes in. We want to make sure that we're also assessing the patient's range of motion, strength, balance, and coordination, and make sure that clinical examination is able to correlate to what we're seeing with the gait analysis. When analyzing a patient via their static alignment, you want to look at the overall length of the lower extremities to see if you see a discrepancy on one side versus the other. You want to see that the base of support is fairly normal, anywhere between 2 to 4 inches. You want to check their center of gravity over their center of mass and see if they're doing any sort of shifting. If they are shifting, why are they shifting? Is it appropriate or is it more than what we'd expect to see? We want to make sure that the patient can regain their center of gravity over their base of support if they were to lose their balance with other challenges that they might have throughout their day. Normal gait has been defined in your book and is made up of 4 different locomotor functions based on Perry and Burnfield's work. In the next few slides, we will discuss these 4 functions. The first one is shock absorption, just kind of like what it sounds like. Results of the muscle activity when loading that stance extremity. So you can think of the gastroc being one of those that can do that as we bear weight on it with initial loading. You can also think of the eccentric dorsiflexor activity, eccentric knee extensor activity, and eccentric hip abductor activity all work to absorb the shock of the limb when it's loaded. The next one is stance stability, and that's going to be determined by ground reaction force vectors, ligament and joint support, and also muscle activity. These ground force vectors are used to determine the flexion or extension moment at each joint of the lower extremity. The static components are required then to control that movement of the lower extremity segment during stance and can be determined specifically and measured appropriately. This is also a very simplistic way of looking at the biomechanics of gait. So we're just essentially using physics and vectors to determine what's exactly going on here. Forward propulsion. That's the result of the body's forward fall, that rocker mechanism ability that we have, which allows smooth translation of the weight over the distal lower extremity. This also creates a bit of momentum created by that swing of the contralateral lower extremity and the active push-off of the stance lower extremity. And the fourth thing is energy conservation. There's selective muscle recruitment that is done that gives efficiency to the muscle by making sure that the muscles are strategic in how they're being used and not requiring too much excessive use or redundant muscle activity. And this is one of those things that we should watch with our patients. As we get older, we tend not to be able to conserve energy as well when it comes to using our muscles appropriately with activities such as gait. An example of this would be the short head of the biceps femoris can flex the knee without unwanted extension of the hip during swing phase. Now we're going to move on to a little bit of terminology. The gait cycle is conceptualized as 8 phases within 3 major tasks. We have the weight acceptance, single limb support, and then limb advancement. In normal gait, weight acceptance includes phases of initial contact and loading response, during which the heel is the first to contact the support surface and the limb absorbs that shock as the weight of the individual is translated onto the stance lower extremity. Single limb support includes the phases mid-stance and terminal stance. During mid-stance, the individual is in single limb support while the other leg advances. The body begins posterior to the weight-bearing foot but moves anterior by the end of the phase, controlled primarily by the eccentric soleus and gastroc activity. And then in terminal stance, the body weight moves anterior to the forefoot and the heel rises from the support surface. Limb advancement is successfully carried out by the combination of pre-swing, initial swing, mid-swing, and then terminal swing. This next table here has been taken from your book. Feel free to look at that, table 17-1, but it is also here as well. So it shows you the selected muscle activity with the 3 primary tasks of gait that we just talked about, the weight acceptance phase, the single limb support, and the limb advancement. On your own, go ahead and pause this video and then feel free to watch the 2 different YouTube videos that discuss the 8 phases of the gait cycle and use these for your reference and your review for the future. Now these next 3 slides are really meant for your reference, but it's just to kind of show you the torque demand, the specific range of motion that's expected at each of our joints, the muscle activity that's utilized here, and then the specific functional significance. For our class this semester, I really want you to think about the functional significance when it comes to using this observational gait analysis assessment in how the patient moves. So really it's just this last column over here that I really want you to focus on when we look through these next 3 slides. And again, I want you just to think about how those work. So the first one was the hip. This next one here in the green is the knee sagittal plane assessment that we're looking at for each of the different phases of gait. And then the last thing is for the foot and ankle sagittal plane assessment. So again, I want you just to really focus on that last column, that functional significance of what that means for how the patient moves throughout space, and the rest of the columns are good for you just to review, but again, that would probably be the best thing for you looking forward when it comes to board prep review. But for this class, we really just need to look at that last column. Now, there are some specific range of motion requirements that we have to take into consideration, and this comes directly from your book, and I want you to make sure that you understand these because this is really important when it comes to working with our patients as they age, because if we don't have some of these basic requirements, it makes gait that much more difficult. And the first is the knee joint specifically. We need to make sure that the patient has at least 30 degrees of hip flexion as well as 10 degrees of hip extension to maintain a normal gait. With the knee, they have to be able to have 0 degrees to 60 degrees of knee flexion. And with the ankle, we want to go from 20 degrees of plantar flexion to 10 degrees of dorsiflexion for proper gait. Listed here are some typical gait changes in the older adults. None of these should be really surprising, but things just to take into context with our older patients as we work with them. We will tend to see a decreased gait speed. We tend to see decreased step or stride length, increased stance time and double limb support time, increased variability of gait, either step or stride time, length, width, frequency, or velocity, so any of these can change, and then decreased excursion of a movement at the hip, knee, and ankle. So like the last slide that we just discussed, that decreased range of motion at any of those three joints can make some big changes, but then we also have to take into consideration any of the other ones. A lot of our patients will start to show some of these changes as they get older. Some of it could be due to a fear of falling, some of it could be from a previous fall and injury, or just specifically being unsure of themselves as they do things. And once we start doing things over time, our body gets used to those kind of changes and compensatory patterns. So we need to make sure that we're appropriately assessing those and finding out why the patient might be deficient in some of those areas. There are also specific individual constraints that we want to take into consideration too. Physiological factors, so we kind of discussed those in the last couple chapters, making sure we're doing a proper assessment of our patient, of their range of motion, strength, motor control, sensation, balance, etc. And then there's also psychological factors that come into play as well. Again, when we talked about in chapter 1, the slippery slope and the decline that patients have there, maybe they're starting to withdraw from activities that they would have previously enjoyed, and asking specific questions to understand what their previous level of function was versus what it is now. And then also understanding, when you ask about the previous level of function, how long ago that actually was that they might have been doing that. I'll have patients that tell me, oh yeah, I used to play golf very recently. And then when you ask them specifics, it might have been that it was 5 or 6 years ago that they last played. So just making sure that we know specifically how long ago it was since they've done some of those activities. Other psychological factors could be depression. And we see that can happen, when patients start to lose some of their independence as they get older. Any sort of fear, so fear of falling, especially in the winter months when it gets icy or snowy outside, patients get very fearful of what might happen. And so in the outpatient world, we'll start to see a lot of our patients start to cancel early just because they're afraid the weather might be inclement and they don't want to get out in it. Maybe they're anxious for one reason or another, whether they've had some sort of issues or someone they know has had issues and they're just concerned that that might happen to them. Maybe an inability to access restrooms, that could be an issue. I've had patients before that will withhold water during the day so they don't have to go to the restroom just because they're afraid that it might be too hard for them to get to and from a restroom. Either, the walk itself might be a little bit daunting, or getting on and off the toilet is going to be challenging for them. And so they just, limit themselves in that way. And maybe even self-image issues. Maybe they feel like they look older because they're shuffling now and because they're not walking as confidently as they once did. So making sure that we're taking all those into account. Gait speed. So the functional vital sign in elderly is considered gait speed, and this is really important. Self-selected gait speed correlates with life expectancy in the elderly. Any sort of slow gait is correlated with future emergence of dementia rather than actually subjective cognitive impairment. So that's really important to discuss with our patients. Again, try to find out why they're having the slower gait. Is it for some, again, that they just have the psychological issues that we need to work through, or is it something else that environmentally we can work through? Maybe it's a strength issue or a range of motion issue that we can help, those physiological factors. But gait speed is very important to make sure that we're analyzing that. And most patients tend to be a little bit competitive with themselves, so doing any sort of gait speed tests are nice to be able to see where they are today and then where they are in the future too. There's a lot of environmental demands that happen throughout our day, and these are things that we need to take into account. When we're younger and healthy and don't have any aches or pains or problems or gait deficits, we don't necessarily notice these as being demands on our body, but they can be a big difference to our elderly population who might have dysfunction due to gait issues or balance challenges. So thinking about these demands such as starting and stopping. So, if you call somebody's name quickly and they try to turn around to stop, that could be a problem, could cause some sort of perturbations and therefore falling. Acceleration and deceleration can cause an impact as well if they're trying to keep up with somebody because they feel like they need to keep up with their family members and they're going a little bit too fast and don't have control. That could be a problem. Changing directions and turning around, that can be an issue. So if they quickly have to, turn corners, or again, if somebody's calling their name and they feel like they need to turn around, that can be a problem and can lead to issues or falling. Obstacle clearance and avoidance. So if there's things in their way or things in the pathway, that can be a demand that could cause further injury or falls. Picking up, carrying, and putting down objects. Obviously this makes a lot of sense too if our patients are having trouble being able to squat to get down to the floor to pick something up. They might fall trying to get something that was on the floor. Pushing and pulling doors, this can be a problem too, especially if the doors tend to be heavier or if patients are using an assistive device. Managing displacement forces, and this kind of goes along with the pushing and pulling of doors because their body has to deal with that displacement of the force. So if a door is heavier or lighter than what they anticipated, that can cause a challenge to the body when it comes to how they manage that force. Any sort of terrain changes, so outside in a yard can be really tricky if they have limbs to pick up in their yard after a storm and they live by themselves. That could be a really big problem where they don't realize that the ground has a little bit of divots in it. Any sort of lighting changes, and we'll discuss this later in the semester, where patients have more challenge with their visual fields as we get older. Weather changes, we discussed that earlier. If inclement weather happens, patients can get a little bit more anxious and therefore they're maybe a little bit more stiff when they move and not moving as fluidly as they normally would, and so that could cause some problems, or maybe somebody's actually slipped because of that. Stepping up and down curbs, stairs, ramps, all those can factor in. So that's where it's nice, for me working in an outpatient facility, I can very easily see outside into the parking lot and can see how patients are navigating our curb or the ramp to get into our facility, as well as doors to kind of see how they do with those. And I can kind of assess that and see, are they tending to grab onto their car as they step up the curb to get onto the sidewalk, or do they feel pretty confident and can just go ahead and do it without, holding onto anything. And then concurrent execution of other tasks. So this can be a mental or a physical type task that you ask them to do. But these are all really great ways to challenge your patient too, to make sure that they're going to be safe out in their environment. Use of assistive devices. The goal, based on your book, is to prescribe the least restrictive assistive device that provides the exact degree of stability and support required by the patient. So you don't want to use too much, like for your patient that can get around pretty well, but that maybe has a little bit of balance deficits. Maybe a rolling walker is too much for them, but maybe for that patient that needs more assistance, rolling walker is most appropriate for them, and a cane is maybe not enough support or stability for them. So you need to figure out what that looks like on that continuum. You need to also be comfortable discussing this with a patient. There are times where patients don't really want to use assistive devices, kind of like we discussed in some of the earlier chapters. If they feel like this makes them look frail or old by trying to use a cane, and they're going to try to get around without using a cane, this could be problematic or potentially dangerous for the patient. And so making sure that you're having those conversations with them so that they understand the importance of using an assistive device. For some of my patients, and actually a lot of my patients, tend to, maybe need to use an assistive device initially, and then hopefully they're going to get off of the assistive device and be independent in their mobility, and be able to tell them that using the assistive device right now can actually improve your chances of getting better faster, because now the proper muscles can work. We're not starting to use any compensatory strategies when it comes to gait. Maybe the lateral trunk lean with somebody that has some sort of hip weakness. But if we give them a cane, it just gives them a little bit of support, and now they can walk with a better form and decreases any sort of low back pain or balance deficits. So just making sure that we feel comfortable having those discussions with patients, because it will come up. And it could go either way, either using less support or more support based on what the patient needs. And then you also just have to make sure that we're doing it from a safety perspective as well. So not letting patients get rid of assistive devices too quickly if it's something that's needed for their safety. Stair negotiation. So stairs are going to obviously require much more range of motion of the hip and knee and ankle, and more strength from the lower extremities than would just walking on a straight surface. So we need to make sure that we understand where the patient is going back to and what they need to be able to do. We need to assess whether they have trouble ascending the stairs or descending the stairs or both. And then again, we got to figure out if this is a physiological or a psychological issue or concern, or maybe it's both of those. So we have to be able to look at those fully and make sure that we understand what's going on with our patient. And then looking at that slippery slope of decline like we talked about previously, and the muscle weaknesses, especially in the lower extremities, because again, that's kind of the fore and the precursor to declining health is lower extremity weakness. And so if we can convince patients to use their stairs, using rails if they need to, whatever way they need to be able to get around in their house or their environment, and doing so appropriately is the best use of their energy, but again, doing so safely as well. So at times I've had patients that just don't go upstairs anymore in their house, and although maybe for a short time that's the best thing for them to do until they get strong enough and stable enough and are safe enough to do so, but then once they are, I want them to start using those stairs again so their body gets used to doing those activities once again. Examination and evaluation of patient's gait. We need to make sure that when we're asking these questions and assessing our patient's gait, really asking the right questions and making sure the patients aren't underreporting any gait difficulties they're having. Sometimes they do underreport because maybe they don't realize how bad their gait has actually become, or maybe because they're just trying to downplay it. So making sure that we really understand what the patient can or cannot do really is going to gain some understanding and gain the ability to appropriately goal set in the future. How long has it been since your patient has been walking? These are all good questions. How far they would go. Asking things like, if they go get their mail at the mailbox, and then also where the mailbox is. For me, my mailbox is just on the outside of my front door, so it doesn't take any real effort at all for me to get my mail. But for some people, it means they have to walk down the block or walk at the end of their driveway. So making sure that we're asking those kind of questions so we fully understand where the patient's coming from. And then looking at gait outcomes. So there's plenty of tools that are validated to assess the gait and balance of our patients. And then we want you to thoughtfully consider which ones you might use and which ones are going to be most appropriate for your patient. And this is something we're going to do with our lab this next week.